Idiopathic scoliosis. Is progression predictable? One of the most difficult clinical scenarios is making decisions about whether a child with scoliosis is in need of referral for bracing or surgery. Although some generally good prognostic indicators have been identified, how they work together to produce a level of certainty has yet to be developed. Let's look at two new studies that are attempts at developing approaches to predicting progression. One involves a clinical prediction rule that divides patients based on their initial visit into low, intermediate, and high-risk individuals. The second study addresses an approach you may have heard about, using genetic markers that identify individuals predisposed to progression. Before we delve into these new studies, let's review some general points about scoliosis, specifically how to distinguish the patients that these two studies are focused on: adolescent idiopathic scoliosis. Scoliosis is assumed by most patients and many healthcare practitioners to be a lateral bend to the spine as visualized on a two-dimensional radiograph. But as indicated by the word scoliosis taken from the Greek word for crooked, this is not bending into one plane. In fact, for structural scolioses, the distortion is in all three planes, causing a twisting and torquing, and when involving a growing spine, these forces change the structure of the spinal elements and become permanently distorted. Idiopathic, as you know, means unknown, which of course means if you can identify a cause, it's not idiopathic. Some obvious causes are structural problems that have to do with differentiation of the vertebral bodies. Broadly, this means a vertebra that is either wholly or partially fused to another, or a vertebra that is only partially formed. Neither can be corrected conservatively and should be referred for further evaluation. Secondly, would be obvious and not so obvious neurological and connective tissue diseases that are congenital or inherited. Here are a few to consider. The least obvious would be syringomyelia, which is often represented by a double major curve that is the opposite pattern usually seen. These patients should have a neurological evaluation and an MRI for possible syrinx. Now to what should be obvious but missed by many chiropractors is a known cause of transient scoliosis: pain. It's uncommon for a child to present with back pain related to their scoliosis when it's idiopathic. More importantly, assuming the pain is due to muscle spasm or subluxation and the curve is secondary to this, correction will often dramatically resolve the problem quickly. Another clue is rotation. When muscle spasm is the cause of a curve, radiographically there is often no rotation of the bodies and spinuses, whereas structural curves have significant rotation with spinuses into the concavity. Secondly, on lateral bending films, functional curves correct, whereas structural curves do not. More importantly, if the scoliosis is due to an imbalance in leg length, anatomical or functional, substitution or orthotic correction is likely to affect the curve dramatically. An important consideration is that during growth spurts, it's not uncommon for one limb to grow faster than the other for 3 to 6 months, reminding us that correction in children and adolescents must be monitored and correction modified. When pain is associated with the scoliosis, the following are important yellow and red flags: being over the age of 15, a riser sign of 2 or more, postmenarcheal status or history of injury. A painful left thoracic curve is often the only indicator of an underlying condition, such as a syrinx. The prevalence of curves more than 10 degrees is only 1.5 to 3%. The prevalence of curves more than 20 degrees is only 0.3 to 0.5%, and for those that are 30 degrees, which are the ones most likely to need bracing or surgery, the prevalence is only 0.2 to 0.3%. Let's look at the current predictors of curve progression. This includes the riser sign and the Cobb angle. For riser sign grade 0 or 1, 22% of curves 5 to 19 degrees progressed. 68% of curves 20 to 29 degrees progressed. For riser sign 2, 3, or 4, 1.6% of 5 to 19 degree curves progressed, whereas 23% of curves 20 to 29 degrees progressed. And here we see the percentage of curves that progress based on the degree of curve matched with age. Note that most progress if they are 20 to 29 degrees if found in 10-year-olds or younger. About half for small curves and about 100% for the larger curves, and the reverse. Very few progress when found in those 15 and older, 4% for small curves and 16% for larger. Several genetic markers have been shown to be associated with the development and progression of curves in adolescent idiopathic scoliosis, including estrogen receptors, melatonin, and calmodulin. Axial Biotech from Salt Lake City tested more than 9,500 patients at more than 100 clinical sites, leading to the development of a 53-gene panel called ScoliScore. This saliva-based genetic test incorporates 28 progression and 25 protection-associated markers, along with the patient's Cobb angle, into an algorithm used to determine the risk of curve progression requiring surgery in patients with adolescent idiopathic scoliosis. This algorithm is used to calculate a numeric risk of progression on a scale between 1 and 200. Patients with low scores, 1 to 50, have more than a 99% chance of not progressing to a severe curve. The risk of progression for patients with intermediate scores, 51 to 180, is 1 to 50%. Patients with high-risk scores, 181 to 200, are associated with a 50 to 99% chance of progression. So when would one order the test? Well, indications for ScoliScore include a diagnosis of adolescent idiopathic scoliosis with a Cobb angle between 10 and 25 degrees, age 9 until skeletal maturity, being Caucasian, and a riser sign less than or equal to 4. So let's look at the first study based on the ScoliScore genetic test approach. The title is, Does ScoliScore Provide More Information Than Traditional Clinical Estimates of Curve Progression? Published in Spine in 2012. The patients' demographics in this study were that they had a mean age of 11.7 years, a mean Cobb angle of 18.8 degrees, 91.2% were female, 8.8% male. 96.3% of female patients were premenarcheal. The clinical criteria used in comparison with the ScoliScore rating were the Lonstein-Carlson criteria using the Cobb angle and riser sign. Here is a table comparison of the two approaches. Now the results. The low clinical risk group had an average ScoliScore of 77. The intermediate clinical risk group had an average ScoliScore of 59.9 plus or minus 55.9 with a range of 1 to 188. Nearly two-thirds of patients in this group received a low risk on the ScoliScore rating. The high clinical risk group had an average ScoliScore of 127.2, again plus or minus 51.6 in a range of 8 to 199. Only 6 of these patients also received a high-risk ScoliScore level, whereas 76.7% of these patients fell into the intermediate ScoliScore level and 4 were low risk. Only 25% of patients were in the same risk category for both systems. Let's look at the breakout of risk groups with the ScoliScore system. Note that there were very few, 8.8%, in the high-risk group and 36.3% in the low-risk group. Here's the clinical risk group percentages. Note the very low percentage of 2.2% in the low-risk group and 47.3% in the high-risk group. Also note that for both approaches, the intermediate group was about 50%. Now, the comparison side to side. Look at the dramatic shift in predicting far more low-risk and far less high-risk patients in the ScoliScore rankings compared to the standard clinical rankings where we see almost a reciprocal. ScoliScore predicted nearly 16 times more low-risk patients and more than 5 times fewer high-risk patients than the clinical risk system. It is these groups in which ScoliScore may affect decision-making the most. Let's move on to the other study, which is the application of predictors at the time of initial presentation of a scoliosis. The title of the publication is A New Risk Classification Rule for Curve Progression in Adolescent Idiopathic Scoliosis, published in the Spine Journal in 2012. Although all usual variables were analyzed for predicting progression based on presenting factors, curvature size was found to be the most important predictor in classifying patients into different risks of progression. Their analysis divided patients into 4 risk groups. Number 1, an initial Cobb angle of less than 19.4 degrees. Number 2, an initial Cobb angle of between 18.4 to 22.6 degrees and age older than 11.3 at presentation, or an initial Cobb angle between 22.6 and 25.8 and post-menarche at presentation. Number 3, an initial Cobb angle of between 18.4 and 22.6 degrees and age younger than 11.3 years at presentation, or an initial Cobb angle between 22.6 and 25.8 degrees and pre-menarche at presentation. And number 4, initial Cobb angles greater than 25.8 degrees. This study provides no new information for those with mild to moderate risk of progression. Distilled down to the clinically relevant groups, we have the high-risk group represented at the time of presentation of curves greater than 26 degrees, and the lowest risk group with a curve less than 18 degrees. So the bottom line? Neither study provides any new or discriminative information for making clinical decisions about progression for patients in the clinically intermediate category. However, for the low-risk group, more patients can be included, allowing less aggressive management initially. And based on these two approaches, fewer patients qualify at high risk, decreasing the need for aggressive management and monitoring of these patients compared to the current practice.